What's that? Because so it wasn't because of SAU, but the place that I have a board only had these that we were in direct contact with someone, but it was like 48 hours. No, sorry, like 72 hours, not the 48 hours.
Oh, gotcha.
Or our work still told us we had to quarantine because we work with kids that have
Oh, gotcha.
yeah.
Yes. Gotcha. This lighter thing you have, it's like, okay, I see how I didn't even think about it. Yeah, I'll pro tip, you can add any spicy water, any kind of, I don't know, yeah, I tried that. Okay, sometimes it's in my mind. It's after you get
I've never had a pool.
I feel so bad for you. Yeah, I know. I feel bad for myself. The only time I've had is a big pool. My mom just got it this year. Really? I have had zero. My grandma was not a little or, yeah.
Try not piranhas.
It's kind of different. Right. Those are things you have to go. Right. Hi, Jess.
Hi guys.
Everything attention. You didn't say anything. You're talking about. I know, I heard it. He was like, oh, she's being uncharacteristic. I know, she's not paying attention. You just have to like focus on. I had a really bad headache since I was watching. No. I still have to go what's going on every Tuesday.
Okay, folks, this is not connecting. So when you listen to this, when I walk away from this, you won't hear me. That other microphone I had was nothing but trouble. So I got one of these. Last time I used one of these, it connected right away. This thing won't connect. Yep,
What is it called?
new B.
Where is it on there? Or it's not on there.
It's on.
That's the problem.
Now, why did it take 20 minutes for it to do? Okay, Jess, can you hear me?
Yeah, I can.
Okay, good. Yes.
What was number 4 on the quiz?
Jess hasn't taken the quiz yet, I don't want to say. All right, back to the ranch here. Okay, we ended up there, right there. Okay. Oh, all right, now for some reason, this recording here is shutting off in the middle of a letter. I don't know why. IT doesn't know why. So I've been trying to do that in case something goes wrong with the YouTube link, but I've noticed that the Audacity, for some reason, shut off. I don't know why. I'm not computer savvy enough to figure it out. Low system resources may affect your, well, fine, whatever. Okay, we talked last time about heart sounds and murmurs and things like that. So the heart valve tissue is a surface that's not completely smooth. If you look at this kind of flip it on its side, look at it in a cross section, It kind of look like this. So it's a little bit rough, a little bit pleated, just a tad rough. Now, if you have an infection with a group A streptococcus, in particular, this causes what is popularly known as strep throat. I'm sure every person in this room has either had it or seen it. When you get this quick strep test at the doctor's office, that's what they're testing for. So this little microbe has a protein in its cell wall called protein M. Protein M projects through the cell wall to the outside and it looks like little spiky dudes, shall we say. These little spiky dudes are highly immunogenic. The immune system mounts a rather robust immune response against protein M. Now, unfortunately, antibodies against protein M cross-react with heart valve tissue. So an antibody, let me do that in a different color. These antibodies they will also be able to bind here. When they do that, they recruit blood-based proteins called complement. And they also recruit white blood cells to this area, and they will damage it. When they damage it, it thickens. Then look at what happens to the surface. What do you see there? Yeah, you see a squiggly line, smart aleck. Yeah, what do you see? Those little grooves got deeper. Now, if they get deeper, what can hide in there? Bacteria. So, if you have dental work, or if you bite down hard on your teeth, the little vessels that connect into the pulp, they get stretched, and some of the microbes in between your enamel, inside the tooth pouch, they get into the blood. They can hide in here. Now, you're going to get an immune response against those. And that is going to cause this to look like this. What can hide in there? More bacteria. So you have dental work, or you bite down nice and hard, or maybe you use illicit drugs or something like that, or what have you, or you cut yourself gardening, or what have you. Now you get more cells. Pretty soon, this valve is going to get really thick. As it thickens, it's going to shorten. It's not going to be able to close anymore. And now these valves are going to look more like this. It won't be able to close. This valve will become so-called incompetent. So if you have, this is the reason why if you have, you always treat it expeditiously, because after 10 days, you will have a very robust immune response against your heart valve tissue. Hence, if you have pharyngitis, you're almost always given a stress. So these small defects usually don't compromise the pumping ability of the heart. If, however, the valve becomes incompetent, then the valve may need to be repaired or even replaced with an animal valve or potentially an artificial one. If the valve gets attacked repeatedly, you can actually get growths of tissue that actually start to grow, that start to grow up into the chamber. And that's called vegetative, and it's have lots of little nooks and crannies where bacteria can hide. That's called vegetative endocarditis. Now that, when you get organisms that get stuck and really are in those nooks and crannies, they're very hard to, it's very hard to treat, very hard to give. So in cases like that, usually you need to take the heart valve out because that's the source of infection. And a patient can be treated, they can seem fine, but they've got this reservoir of infection in their heart valve because of this repeated cycle of damage, thickening, damage, thickening, damage, thickening, and so on and so forth. That will tend to cause a murmur that you will start to hear instead of, now you might get a, or something like that, or it might be something like that, depending on how badly the leaflets of the valve fit together. So some of these can be benign, some of these can be quite serious. So it depends on the space, it depends on how well the leaflets together. And if you had any sort of infectious disease, we had very high fever when you were a kid, you may have some heart valve defects so that you may have a small murmur. Like I said, my dad had murmur and it never affected him. All right, question on heart sounds or rheumatic endocarditis or vegetative endocarditis or any of that stuff like that there? No? And we will sort on. So the myocardial cells are attached to each other, and when you look at the junction between them, you have these intercalated discs, as they're called. And if you were to look very, very intently at these and take them, turn them on their side, and look at them with very, very high resolution, you'd see something like this. You'd see a membrane, and decorating this membrane would be lots of these little tiny channels. And these essentially would be just like this. There are gazillions of these sitting in the membrane. Now, what are these? These are gap junctions. Are they big? No, but they're small enough, just big enough, so small molecules or ions can readily diffuse from one cardiomyocyte to another. That means if you have ionic changes in this cell, it spreads instantaneously to the next cell. Therefore, the cardiomyocytes of the heart act as a connected unit. That's what we mean when we say a myocardium. It functions as one big giant cell, a functional syncytium. And action potentials that originate in one cell spread very quickly to all the other cells. Now the signal, beat, originates in the atria. Remember, the atria functionally are cut off from the ventricles. Remember why? Fibrous skeleton. Fibrous skeleton. The fibrous skeleton physically, functionally rather, well, and physically, separates the atria from the ventricles. How then, if the signal to beat originates in the atria, how do you get it down to the ventricles? You have a conduction system that kind of, sort of, acts like an extension that goes from the top of the heart down through the septum to the bottom. So the place where the original action potential is initiated in the heart is in the upper part of the left atrium. Sorry, right atrium. Right. L, left, right. Right atrium. This is called the sinoatrial node, sometimes just known as the sinus node. They get called both SA node, SNODE, whatever you want to call it. These cells have the ability to spontaneously depolarize. And during diastole, they start to exhibit slow, spontaneous depolarization that is called a pacemaker potential. Soon as they depolarize, automatically start repolarizing slowly right away. So the memory potential will start at about minus 65 millivolts. Its resting memory potential is relatively high. It will depolarize to round about 50 millivolts-ish. That is threshold for the cell, 50. Minus 65 to about 50. This pacemaker potential is due to a subchannel called an HCN channel. Now you may look and say, oh, hydrogen cyanide. No, not hydrogen cyanide. HCN stands for hypersensitive to cyclic nucleotides. Hypersensitive to cyclic nucleotides or hyperpolarization activate cyclic nucleotide gated channels. Those open, sodium comes in. Depolarize the cell, but slowly. Gets the threshold, then you start to open voltage gated channels. So here is the electrophysiology of the pacemaker. Now, gang, I show you an electrical profile of the other cells, they're not going to look like this. Please, if you have this slide in front of you, write on it, pacemaker cells only. Pacemaker cells only. When pacemaker cells initiate their action potential, remember, it spreads to the other cells. This is only for the pacemaker cells. So here is your repolarization. Then you open the HCN channels. Sodium starts to come in. Once sodium starts to come in, you then open your voltage-gated calcium channels. Voltage-gated calcium channels. Open, calcium now enters the cell quite quickly. These sometimes get called fast calcium channels. That's a term you may have seen before. That's what those are. Calcium comes in, the cell depolarizes rapidly, very rapidly. Gets up to about plus 20. These channels will start to close. Then you open the voltage-gated potassium channels. Potassium now will start to leave the cell. Leaves the cell, you now repolarize the cell, and those channels will close. You get to the bottom, you go back to go collect $200 and go again. They open, make a potential, it's a threshold, fast calcium channels open, up here you go, they close, potassium channels in, down you go, and repeat. Rinse, wash, repeat, so on and so forth. Those are your pacemaker cell physiology. So these fast calcium channels are called T-type calcium channels. T-type calcium channels. They're a voltage-gated channel. And you have the flux of sodium and calcium. You depolarize the cells very quickly. Half a millisecond. Very, very fast. Then the calcium and sodium channels will shut, potassium channels open, you repolarize. Once you get down to the bottom to minus 65, pacemaker potential starts anew because the HCN channel is opening. Now, why do these channels get called hyperpolarization sensitive cyclic nucleotides? The reason for this is that these are sensitive to cyclic AMP. Remember, norepinephrine and epinephrine make the heart beat faster, right? That's one of the adaptations to exercise, is the release of epinephrine, norepinephrine from the adrenal medulla. That increases the heart rate. And you get some people exercise, some people very gradually increase the heart rate, others, the heart rate shoots right up. You call them heart rate sensitive, that's what you call them. Help me out here, gang. You have that before? No? There's some athletes, the heart rate when they start exercising, rate goes up really fast. Others, takes a while for the heart rate to go up. And there's a term for that, and I don't remember what it is.
Is that more efficient?
Sorry?
Is that more efficient if it goes up?
Tends to run in families. It can be. In trained athletes, if they get up really fast and they do something really quickly, then they sit down really fast, they may start to get a little dizzy because of the postural changes. Because the heart rate works so fast, it doesn't quite catch up with the posture. That might be a side effect. In a well-trained athlete, I doubt it. I doubt it. So these are going to open faster. And that's what actually causes the heart to beat faster, is that these now, instead of that, this having a slope like this, now they have a slope like this. That's how you get a faster heart rate as we're in response to epinephrine, norepinephrine, because those will bind the adrenergic receptors and they'll cause an increase in the intracellular concentration of cyclic AMP. So let's look now at your non-pacemaker cells, your non-pacemaker cells. Once you get the action potential in the pacemaker and it starts to spread to nearby cells, those cells will get to threshold. These cells usually are at about minus 90 millivolts. When they are moved to threshold, they open their own VG sensor voltage gated, in case you're wondering. They're voltage gated sodium channels. They open and the cell depolarizes very, very quickly. Very quickly. That's how fast it polarizes. Boom. Just like that. So the repolarization, however, occurs in a couple of stages. It's slow. Reason for that is that once the voltage-gated calcium channels open, there's going to be a war between potassium efflux and calcium influx, because you have the so-called slow calcium channels that open to, you're going to get a plateau stage. During repolarization, the influx of calcium versus the outflux of potassium going to cause depolarization to be much slower than you saw in the either nerve cells or pacemaker cells, because of this tug of war between calcium and potassium. Why does the cell do this? So it has enough calcium to be able to contract. And so this is broken into stages 0, 1, 2, 3, 4, like this. So sodium in, calcium in, and potassium out. And then eventually just potassium out. Then you're back to resting potential at about minus 90. So the stages, you have resting potential, stage 4. You then get to polarize to threshold, minus 90. Stage 0 is depolarization, very fast, steep depolarization to minus 3. That is due to opening of voltage-gated sodium channels. Then you get to stage 1. You start to repolarize. You get to about 0. But then you have the plateau stage, the slow repolarization due to the opening of the low calcium channels with the opening of the voltage-gated potassium channels. Potassium eventually will win. You repolarize back to stage 3, and then you go back to stage 4. Yes, because the slow calcium channels start to close. Now, cardiomyocytes have a mechanism that is different from skeletal muscle. They have a phenomenon called calcium-induced calcium release. Calcium-induced calcium release. when you have the opening of the voltage-gated calcium channels, calcium enters the cytosol quickly. It binds to these receptors on the cardiomyocyte sarcoplasmic reticulum. These are the so-called ryanodine receptors. When they do that, you get a gush of calcium internal stores entering the cytosol. That induces cardiomyocyte contraction. This is very different from what you see in skeletal muscle. In skeletal muscle, you have the T-tubules. The T-tubules, as they depolarize, you have a physical connection between the calcium channels in the T-tubules and the release channels in the SR. This is different. Here, you don't have that physical, gosh, that's hard to see. You don't have that physical connection. Instead, you have a calcium release channel. When it binds calcium, it releases calcium. So this release channel, when it releases calcium from the outside, that only raises calcium a certain level. You want more calcium to be able to contract. Calcium now gets released. You contract, then the circopump will retrieve calcium back into the sarcoplasmic reticulum, and the muscle will relax. This is unique to cardiac muscle. Unique to cardiac muscle. Also, if calcium is released in a cardiomyocyte, can it spread to others? Yes, it can. That's the other reason why these cells are going to work as a unit, a functional unit. So the pacemaker cells are connected to all the other cardiomyocytes because of these gap junctions found in the intercalated discs. So you have spread from the SA node to the right and the left atrium pretty quickly. For that reason, the right and the left atria will tend to contract largely simultaneously. That's not the case for the ventricles. As these contract, a signal, however, gets sent from the atria down to the ventricles, and we will look at that system right now. It's mentioned here. There's a specialized set of tissues. They're modified cardiomyocytes. The modified cardiomyocytes work to conduct the signal to beat. The signal to beat spreads across the atrium, and it gets down here to the base of the right atrium. It counters tissue known as the atrial ventricular or AV node. Atrial ventricular or AV node. This is the beginning of your extension. Also, notice it looks a little bit like the head of a snake. That's going to become important when we get to the next piece. So, from the head of the snake, the signal after it's up, they're part of the cardiomyocytes. They pick up that signal to contract. Then they go down through the septum. And this here, it's the head of the snake, so it's a bundle of his. Okay, it's stupid, but if you remember it, then don't laugh. Okay? The bundle of his. Just like the snake. The head of the snake is the AV node, and there's the bundle of his. Not the bundle of his, bundle of his. Then it splits. You have the so-called left and right bundle branches. It splits. And it goes down these bundle branches and swings around. Goes down apex, swings around. One goes up to the left ventricle. It goes to the right These branches of the bundles are called Purkinje fibers. They are going to give the signal to individual pieces of the ventricle to beat. So these, therefore, are going to get the signal, and then they're going to contract. So it's from the AV node, and it's located at the bottom of the right atrium portion of the atrial septum, very close to it. Then you have the bundle of His. That starts at the top of the interventricular septum. Then you get the branches that divide right and left. Then it becomes Purkinje fiber as it swings around, causing the ventricles to contract a tenth of a second apart. Now the speed is going to vary through this conduction system. So the action potentials through the SA node, through the atria, very fast. Fast as a meter per second. That's pretty fast. Gets to the AV node needs to pick it up. That bit. Once it gets from there, passage through the bundle of His is very fast, up to 5 meters a second. Then it goes to the ventricles, and you'll have this contraction a tenth to 2/10 of a second after the atria contract. Now, think about this with me, please. What happens if you have a heart attack and you kill off some portions of the heart? What's going to happen to your conduction now of the signal? You get a block, don't you? And now you have to find a way around it. Finding a way around it might cause the beat to start, go here, and then detour, and it might get lost. Or it might go down and then come back up, in which case you get what's called a circus rhythm. You get a circus rhythm, you get these really, really miserable arrhythmias. Miserable arrhythmias can cause the heart to beat dangerously fast for a weakened heart. That can cause a second heart attack. But this is a big issue after a heart attack, because heart attacks most commonly occur in the LAD vessel, and that vessel tends to occur a good portion of the septum and the left ventricle down the apex and what have you. So that's all something to keep in mind when you're looking at cardiac rehab purposes. Now, the electrocardiogram gives you an electrical profile of the heart. The electric potentials of the heart will be also produced into the skin. There'll be small amounts of that electrical activity in the skin. You can detect that by putting an electrode in the skin over the heart. The Cadillac version of this is a 12 lead EKG. There are single lead EKGs. They give you essentially one little snapshot of the heart. The 12 lead essentially allows you to get a snapshot of the heart like this, and like this, and like this, this, and like this, and like this. It's very powerful, very, very powerful tool, because essentially gives you a reproduction of the electrical activity of the heart throughout the entire chambers of the heart and all the sides of the heart. And that is the cardiologist, cardiac rehab tech, and so on and so forth. That's probably a little better. Now, the cardiac cycle produces 3 waves during the EKG. They get designated P, QR, S, and T. Those are the 3 waves. P, QR, S, and T. And if we look at the depolarization, repolarization profile of your ventricular cardiomyocytes, and you overlay with the EKG, you can see this depolarization corresponds perfectly to the midpoint of the QRS wave, thus suggesting that this, in fact, is ventricular depolarization. That's exactly what it is. QRS wave represents ventricular depolarization. The P wave represents atrial depolarization. Atrial depolarization. The T wave represents ventricular repolarization. Ventricular repolarization. You're probably wondering, where's atrial repolarization? Very small, and it's obscured by QRS. If you don't have a QRS wave because of a block, some cardiologists have told me you can see atrial repolarization. It's still very small, very easy to miss. So it's sometimes there, but very often you don't see it because it's so small. There are various intervals that are of interest to cardiologists. The P to R, S to T interval, P to Q interval, S to T interval, so on and so forth. And there is a so-called QT interval that is of interest to psychiatrists because there are several drugs that psychiatrists use that increase the QT interval. And they are of interest. You have to watch that if you're a psychiatrist and you put people on series of antipsychotics. The biggest offender being the drug ziprasidone, which by the trade name Geodon. None of you have probably heard of that drug, so that's a tidbit of worthless information. Abilify, ever heard of a drug called Abilify? Abilify at high doses will do that. It's not very common, but at normal doses, it doesn't affect the wave at all. Yeah, anyway. Okay, so the P wave, that is atrial depolarization. Depolarization. QRS is depolarization of the ventricle. T wave is ventricular repolarization. Repolarization. And this picture simply shows you, as you get the spread of the signal to beat, how you reduce these various waves and what you, and I will let you basically take a look at that. And we'll go on now to the next chapter. All right. So the cardiac rate, the heart rate, is measured in terms of beats per second. Beats per second. That volume of blood ejected per beat, that's a stroke volume. That's a volume. Beats per minute, not beats per second. I said beats per second? Yeah. Beats per minute. Beats per minute. Beats per minute. So these devices that we wear, they will give you essentially beats per minute, and they will essentially tell you essentially what your heart rate and what have you, blah, blah, blah. That's what they're trying to tell you. So the stroke volume, cardiac output then is going to be the stroke volume, milliliters of blood that are pumped out for each beat, times cardiac rate. And if you notice, beats are going to cancel. So you get milliliters per minute. And that is going to give you cardiac output. Cardiac output. Now, stroke volume can also be calculated by taking a look at diastolic volume and subtracting it from the systolic and systolic volume. That's going to give you your stroke volume. So let's say our end diastolic volume is 120 milliliters. And let's say our end systolic volume is 50 milliliters. Your stroke volume then is 70 milliliters. So that is another equation essentially for calculating stroke volume. Now, if you know stroke volume and you know end diastolic volume, there's another equation you can use to calculate ejection fraction. So ejection fraction is going to be equal to the stroke volume divided by end diastolic volume. That will give you the ejection fraction. And that will be a decimal fraction, which you can convert into a percentage. The normal ejection fraction fluctuates between 50 and 65%. So it's in the vicinity of 58%-ish, something like that.
Don't we hire, I guess, for like a professional athlete,
Yeah,
lower versus
yeah. The bicycle athlete, Floyd Landis, I think his name was, he rode with Armstrong. So he was, they did him for doping and took away his medals. He admitted to a, oh gosh, what was it? I think it was Boston University exercise phys group, and they measured his ejection fraction on a bike. His ejection fraction was something like 80% or something like that. He has the highest recorded ejection fraction of any athlete. The guy's just a monster, absolute freaking monster. So the average blood volume is about 5.5 liters. That's ballpark. Your ventricles will pump this at rest about every minute. And during exercise, depending upon the intensity of the exercise, this of course will increase. Here is the distribution of the blood during rest and during exercise. Now, during exercise, you have the production of epinephrine and norepinephrine by the adrenal medulla. Those will bind to beta 2 and alpha 1 adrenergic receptors. They are going to decrease circulation in the gut and in the peripheral areas of skin, places like that. They'll cause vasodilation in skeletal muscles. So if we look at the difference between rest and exercise, so let's say, for example, skin, we will know, for example, skin really gets the shaft during exercise. This is one of the reasons why going out and running in the snow in short sleeve shirts and shorts is a really bad idea. You can damage your skin and you won't know it because Ram, I've seen you guys out in the snow. You guys don't wear shorts. You wear gloves?
You wear shorts.
Well, most of you guys are pretty, you guys are lycra and stuff like that. You guys are pretty well set. You won't be able to feel it. In fact, as you start to get vasodilation, when you come in, that vasodilation, notice the difference in the kidney. Vasodilation might actually cause the glomerulus to actually separate. You might actually start to get your urine. That actually happened to my brother. He told his doctor that, and his doctor said, "You idiot, don't ever do that again." And Tom never did. So yeah, it's just a very bad idea to do that. Now, look at the distribution of blood in skeletal muscle at exercise relative to rest. Tell me what you see. Yeah, big disparity. That's due to beta 2 receptors in the muscle causing vasodilation. Beta 2s, beta 2s. Now, the beta 1s are going to cause the heart to beat faster. Now, one organ I don't see on here is the lungs. Because of the increase, you're going to beta 2 receptors are going to cause bronchial relaxation in the lungs. You'll have increased O2 in the alveoli. That will cause vasodilation in the lungs. So you have increased circulation in the lungs and increased O2 in the bloodstream. That's in the arterial blood because the venous blood will have increased CO2 and decreased O2. Notice the GI tract. Now what you see. Big difference. You have blood vessels cinched down. It's your coach telling you, don't eat before practice like an hour or something like that. Because that food is going to sit there. You won't be absorbing it. There won't be a lot of movement in your GI tract. It's going to potentially irritate your gut. That's why some people will run, and then if they've just eaten, and then they turn over the side and they puke, essentially. To prevent, you're not supposed to eat usually hour and a half, something like that, before exercise. Now, if it's light exercise, probably not a big deal. Like if you're going to go for a walk, I doubt it's a big deal. If you're going to, do a Remington 3, 4, 5, 6, 7, 8 miles, yeah, don't eat. Don't eat. You guys, I've seen the way you guys work out. No. You don't want to eat before your workouts. Now, before a game, I'm betting you have a light workout. Yes? Yeah, before a game. It's a day before a game. Okay. So, yeah, and you've probably, there was a joke at least where I went to school, there was a joke on the wrestling team. They'd tell the freshmen, hey, not going to get dinner till late. Make sure you eat really well before practice. Then the coach would say, okay, wind sprints. And these guys who just had spaghetti or something, going on doing wind sprints, and all of them just, the uppers would be sitting there laughing their heads off as a freshman, which I think is a pretty dirty trick, but I guess they should have known or something. And Corinne, no, I'm sorry, didn't leave you out.
What?
You guys work hard too.
Sometimes.
Sometimes, okay.
I do too, Brad.
All right, I think that's our time. Okay, Jess. I'll see you later.